Hey everyone out there at Go4 Nation, good to see you here. Thanks for joining me today. Today we are starting up our first multi-point series on it's going to be concussion, and I'm just waiting on our guest here. Should be in here shortly. There he is. All right. There he is. How you doing?
Hey, what's going on, Josh? I'm doing great. How about yourself?
I'm doing well. It's good to see you. So again, just want to thank everybody for joining us. We're starting up kind of a multi-point series through Instagram, as well as our blog on concussion, and it's featuring Nick Pfeifer from Boston University. Nick is currently athletic trainer and core residency faculty member at Boston University. He has an area of clinical specialty in neurotrauma and spine pathologies, and he has a particular passion for concussion assessment and rehabilitation. Nick's given presentations all across the country on diagnosis and management of concussions, and we're fortunate to have him with us today. So, Nick, thanks for being here. I appreciate your time. I know you're busy. There's a lot going on. So, thanks for showing up.
Yeah.
So, just to kind of kick things off a little bit, tell me a little bit about your role at BU in concussion management and kind of what all of that entails.
Yeah, absolutely. So we have a great system here, really, in practice, to be able to support our student athletes and also our students here. So institutionally, athletic training services here at BU is housed within our student health services department. So we have access to, primarily provide care for our student athletes, but also to have access points with the general student body as well. So as it pertains to our athletes, we provide direct care, event coverage to all of our varsity, club, and ROTC student athletes and cadets. We have walk-in availability in our clinics for all of those students as well. We also have a presence on campus in our student health general clinics that's open to the full student body. So we have a day a week. We have one of our neuro residents housed over there, open to appointments for students at the university at large. And then we work with other stakeholders that are involved in care. So certainly our coaches, athletics directors, strength conditioning staff for our varsity student athlete needs, and interact a lot with Office of Disability Services on campus and the Student for Academic Services to coordinate with any needs academically for our kids that have sustained concussions.
Okay. Yeah, I know in working in that model in the past and things like that, it's really a great team-based approach. I know you work closely with behavioral medicine as well for those student athletes and those patients that kind of need that level of care as well. And I mean, as ATs, certainly we all recognize the importance and understand the importance of early recognition of the signs and symptoms. How do you kind of illustrate that importance as well as the dangers of delayed care to other non-healthcare professionals?
Yeah, so we have great contact points with our student athletes where we have minimally annual education opportunities with them around concussion specifically. So during those times, it's a great opportunity for us to dig a little bit deeper into some of this education material. And usually the way that I like to try to portray it to both the student athletes, but also the administrators, the coaching staffs, and then the academic folks that are involved, is to highlight what really we're seeing as an effect from this injury, right? We know participating in athletics, there's inherent risk that this is going to happen, right? And we want to try to do everything we can to reduce the risk that it's going to happen. But at the end of the day, there's going to be circumstances that it's going to happen, which is why we're there to be able to manage this. So some of the points that I like to highlight is most certainly when you have a concussion, you're going to feel pretty crummy. So we want to try to avoid that most certainly. But as to try to speak into the language of the student athlete, some things that we've seen in some of the research over the last few years is that delayed reporting of those concussions in patients that have delayed the reporting, they've actually started to see extended recovery times as compared to patients that report their concussions immediately. So those that continue to play with that concussion tend to take longer to recover, which time is money. And when you're speaking to kids that are participating, more time lost is going to be something that speaks to them pretty directly. And also, there's a increased risk for lower extremity injury.
There for a second. Uh-oh.
I'm back. Can you hear me?
All right, I got you. Yep.
All right.
Sorry about that. I know we missed a bit of that. I know you were talking about increased risk of lower extremity injuries.
Yeah.
Right? With concussion.
Absolutely. So we see that as a big risk. And then the second point I was making off of that is also a direct decrease in reaction time as well, which leads to diminished performance. So to really put it into actionable terms for, our student athletes and our coaches, we're going to see these kids, if they try to play through this injury, they're going to take longer to recover. They're going to have potentially complicated recovery with more risk for other injuries. And their performance is going to be decreased, so they're going to be less valuable to the team from a strictly team performance-based model. So we're looking at three variables that speak that same language that they might care passionately about outside of
his setting in the Division I in the clinic realm there. And one of the points that I really wanted to touch on because is secondary sports, youth sports as well, because a lot of times delayed access to care athletes, and I know that concussion numbers have come down a little bit over the last few years. And I think a lot of that is because of increased education around it. But this is still one of the leading causes of death in athletes and young athletes. And we've unfortunately already had 2 cases of high school athletes dying from concussion just this year. I think there was one in April in the state of Washington, and then there was one, I think, last month in New York. So this is something that early recognition and things like that is still of utmost importance to make people understand. And from just kind of changing gears a little bit to that assessment piece, right? I know the majority of us have had the SCAT-5 or the SCAT-3, or, depending on how long you've been in the game, we can really administer these in our sleep. But are there any other kind of emerging tools that might be viable options, particularly on a sideline setting where, if you're in the middle of a game, there's a lot going on. It can be tough to go through some of these memory sequences and things like that with the patient. Is there anything that's kind of emerging in the research that could be a good option on the sideline?
Yeah, definitely, Josh. And to your point, the SCAT's still always going to be the main tenet of what my exam looks like, just because it's the most diverse tool that we have to cover the most, range of profiles of impairment. But certainly there's some attention in the research looking at the vestibular ocular motor screen in a sideline setting, which I think is starting to show some utility. We know in a clinical setting, the data is really, really well correlated with concussed patients, and they're starting to see some of that correlation in the sideline setting as well. So I think that's a tool that, even if you think independent of the data at this point, the theory of that tool makes a lot of sense about why it would be applicable in the sideline setting. And I think, really, when you look at what the SCAT-5 involves, the 2 things that it doesn't do it doesn't have a large incorporation of is going to be that vestibular system and that ocular motor system. So if we think about some areas for focus on that sideline setting, it's going to be that vestibular ocular setting and even some reaction time component as well. And I'd say those 3 systems are 3 areas of emerging, confidence for the sideline environment, whether it be through the VOMS assessment, probably the most common strictly visual assessment at this point in time is the King-Devick test. And then there's some various forms of validated reaction time measurements as well that can really start to look at, those three profiles in that more immediate setting. So I think that those are some things that situationally I'll definitely use sideline environment, in combination with, with my SCAT assessment, with my neural screen, and then a cervical spine assessment as well. Understanding that these are high velocity injuries and you can certainly have some of those other things present with them that have some symptom overlap, like a cervical spine ligament or muscle injury too.
Yeah, absolutely. It's always important to remember to clear C-spine when you're working with these injuries acutely. Now, as far as your sideline assessment goes, have you started to bring in like the VOMS or the King-Devick or anything like that on the sideline?
Yeah, I'm doing it right now, Josh, in in more case situations. I haven't used it at a population level yet. I think as we, or at least for myself, department-wide, as I look to start to push towards some of those changes, I definitely want to, continue to have some momentum with this research that's moving in that direction, build, accent what we're looking, to accent what our exam looks like right now. But there's definitely case circumstances that I've been incorporating those tools and certainly looking at it in the return to play component, directly as well. Because I think in a lot of our baseline screenings, similarly to our sideline assessments, these types of components aren't always acknowledged. So I think that that's really the first point that we're looking at to bring them in to really understand that value added. And then as we get that confidence to continue to grow, then it's got a really clean pipeline to be used at a population level sideline wise.
Yeah, that's great. Because I know that, like I said, sometimes the SCAT and, trying to go through the memory lists and the number lists and things like that, sometimes it's hard for the patient in front of you to hear you. It's hard for you to hear it back. Like sometimes with the chaos of everything going on around you, it can be really tough to get a good exam in. So obviously.
I think one more thing there too, there's a lot of, we're living in a technological age right now, and a lot of the tools that we rely on have been, fairly old school in terms of the technology we use to administer them. And there's a lot of attention with technologists looking at different ways to try to assess, measure, and interpret what's going on with the visual system. So I'd say that that's a really big focus in the research right now, in using technology to try to objectify that exam a little bit more, as much of it is very subjective in nature, and to try to be able to tie some data points into that exam, certainly through the visual system, is something I see coming in the short future. Okay,
great. Yeah, I know we'll go kind of into some more of the specifics of that exam and kind of a later installment. We'll talk about that a little bit, and same with treatment. But I want to touch on treatment a little bit because I know the research is showing more and more that early activity is much more beneficial than we once thought, right? So really trying to incorporate activity in a lot of these patients that have sustained concussions is becoming much more important. How soon have you been kind of integrating activity with your patients, and how do you determine their capacity for, to be ready for that? Is it based on symptoms, or, kind of what's the decision making algorithm there for you?
Yeah, absolutely. Our philosophy here at BU is certainly in line with that. We're big enthusiasts of early activity, early initiation of rehabilitation programs. So, typically we're looking to allow about 48 hours of recovery after that initial injury, and then we're looking to get started with some rehab. So there's going to be some guidance based on what the primary symptom profile is of that patient. And we usually start to see that get a little bit more focused kind of within those first 2 days after that injury. So as we start to see those symptoms, cluster a little bit more or calm down from that kind of initial trauma point that they're at in the first 2 days, then we look to try to dig into what the root cause might be and establish some expectations and goals for starting our rehab. So one of the first tools that I'll use to inform that decision is going to be either the Buffalo concussion treadmill test or the adoption into the bike version of that John Letty and his group in Buffalo have validated over the last few years. And the real goal with that is to try to establish exercise tolerance so that we can start that rehabilitation process and also prevent, some secondary negative effects from inactivity and kind of allowing the body to operate underneath what its normal threshold is. So it's really mutually beneficial in that regard, that it's going to help, try to combat some of that secondary effect, but also accelerate that rehab process. So we're looking right around that third day. We're starting that intake process in the in the clinic, and getting, looking to get started with minimally some symptom limited exertion if the patient's able to tolerate it.
Okay, so you're saying within 48, 72 hours, in most cases, it's pretty safe to kind of start doing some exercise and some light activity, obviously based on some of the guidelines through the Buffalo concussion treadmill test or the bike version of it.
Yeah, absolutely. And what we know about it is when you follow the principles, it's really safe. So we're not concerned about causing damage or trauma or anything like that, because we're able to operate within a symptom limited environment. And that's why those tools are really helpful, because they help to establish what that ceiling is that we're going to work at. And then we take a percentage of that. So if, at 140 beats per minute, for example, the patient starts to have, symptom problems, we're looking to operate 75-80% of the time right up against that ceiling.
Yeah, and then just kind of gradually increase it as they improve, right?
Yeah, absolutely.
Okay. Yeah, that's really great information, and I know like I said, we're going to get into that a little bit more. And Nick's got some great blog posts planned for us, as well as a couple more Instagram lives. So definitely keep your eye on the blog and things like that, and we'll obviously be letting everybody know when it's out. But Nick, your expertise and time, as always, is very much appreciated.
Yeah,
I know that a lot of the things that you do with your patients and the word that you're getting out on concussion and kind of the current concepts, I think it's really important for everybody to look at that and listen to it, because this is, obviously concussions aren't going anywhere. They're going to continue to happen. And I think that the way that they can be treated and evaluated is evolving. So thank you for coming on and chatting with me. I don't know if anyone has any questions that they want to drop in the chat, but if they do, now's the time. But otherwise, Nick, thanks again. I don't know if you got any parting words of wisdom.
Yeah, man, I appreciate the opportunity to speak here. I always close with this in this context, that I think athletic trainers are the most well-positioned healthcare provider to manage this injury because of our access to our patients and how we can see that from injury all the way through discharge. So there's no lapse in care, no time loss. So athletic trainers keep fighting for our right to be able to provide our patients care, because we have, a really, really great opportunity to impact.
Yeah, absolutely. We did have one question come in here from our friend Dan Gilfeather. He's asking, in regards to baseline testing for someone who works with no sports medicine physicians, he's working mostly with internal and family medicine. How do you recommend going about proposing baseline tests, whether that be impact or something like that?
Yeah, so my perspective on that is you want to identify what's going to be most actionable for your staff so that you're best utilizing your healthcare dollars. So baseline testing is very poorly defined in requirements for, I work in the NCAA setting, so I'll speak for that. And I mean poorly defined in the sense that it's not prescriptive. It's very open for interpretation in terms of what you can use for that baseline assessment. So I would look at what's going to be actionable. We use the impact test as a component of our baseline exam here at BU, but we have the capacity between our sports med staff, physicians, athletic trainers, and residents to be able to apply that test, interpret it, and use it to inform, recovery and return to play decisions. So if you don't have those resources, investing that money in that system might not be the most effective time spent or resources spent for you. So I might advocate for identifying lower cost options that will provide you more impact in your management decisions, like maybe a SCAT5, a VOMS, or King Devitt, something that's going to be more accessible to you in the moment and also influence your care decisions directly, maybe in that acute environment, and then certainly as a component of that recovery return to play process as well, if that price point or resources is a big barrier.
Okay, that's great information. Thanks for that, and Dan, thanks for the question. So again, just last time, Nick, thank you for your time. I appreciate it. I'll let you get back to work, and we'll talk to you again in a couple weeks on here.
Looking forward to it, man. Thanks a bunch. Thanks for everybody.
Thank you. We'll talk to you later.